All right, welcome everyone to tonight's 2022 NEPA Updates and Epilepsy Conference. We're going to go ahead and get started in just a minute. You should see on your screen a pre-survey. If you could please go ahead and fill that out, we'd greatly appreciate it.
Hello, everyone. Good evening. Welcome to our 2022 Updates in Epilepsy Conference. This is an expansion of the Northeast Epilepsy Conference. Since we're hosting virtually this year, we wanted to make sure that this program was open to our full epilepsy community and that all felt welcome to join tonight. We have a wonderful program. planned for you. We're so excited to have you join us. And before we get started, I wanted to give a big shout out to our Northeast PA support group, who is gathered together tonight watching in person as a group. So hello to all of you, and thanks for joining us. So some quick housekeeping notes. Obviously, we're all tuning in virtually this evening. So your audio and your video will be muted for the entirety of the conference. So you're able to just come as you are, but don't worry about, interrupting or anything like that. If you have any questions, feel free to pop them right into the chat box. We will be holding all questions until the end of each of our presentations this evening. And then our Greater Philadelphia Resource Coordinator, Seamus Morgan, will be facilitating and moderating Q&A. But you can also feel free to utilize the chat box just to say hello and let us know that you're here joining us this evening. So we always like to kick off our conferences by reminding you that you are not alone in your epilepsy journey. As we know, epilepsy is very much so a hidden disorder. Unless you were to have a seizure in front of someone, no one necessarily would know that you're living with epilepsy. But because of that, not many people talk about having epilepsy. So people often feel alone in their journey, and especially right after you're diagnosed. But the truth of the matter is, epilepsy is quite common. 1 in 10 people will have a seizure at some point in their lifetime, and 1 in 26 people will be diagnosed with epilepsy. Right here in Eastern Pennsylvania, in the EFEPA's territory, there's an estimated 110,000 people living with epilepsy. So 3.4 million right here in the US. So it's really, it's much more common than people think. And we like to come together to raise awareness, to spread education, and to really build community around epilepsy, because we want to make sure that you feel supported. And we think the best way in doing that is arming yourself with knowledge and education. So tonight is the first step in furthering your epilepsy education. So a little bit about who we are at the Epilepsy Foundation Eastern PA. We are an independent local affiliate organization of the Epilepsy Foundation of America. We get to be the direct boots on the ground support services, serving and supporting our local epilepsy community. We do that by providing a wide range of support services, educational programs, resources, and referrals. As you can see with the map right here on our screen, our main office is right in Center City, Philadelphia at 9th and Walnut, but our programs and services go all the way up to the Scranton-Wilkes-Barre area, out to Lancaster, the Lehigh Valley, and everywhere in between. And in each pockets of those territories that I just named, we have a local resource coordinator who lives and works directly in the community, providing the programs and services that we provide free to our local epilepsy community. So a little bit about the programs and services that we offer at the foundation. Again, our local resource coordinators, a big part of what they're doing is going into our school districts, leading seizure recognition and first aid trainings with teachers, school nurses, the students, personnel, school bus drivers. They lead these trainings as well with caretakers and spouses and partners, as well as the general public and corporations. Whoever will have us, we want to make sure that we are providing seizure recognition and first aid training. Again, we feel that education is such a big part in furthering understanding and awareness of epilepsy. And we think it's the best way for us to build a safe and supportive community for those living with epilepsy. Our resource coordinators also lead monthly support group meetings all throughout our region. Those are currently still happening virtually as well as in person. So you're really able to tune in or join as they fit in your schedule. We also have a few support groups that are specifically tailored to different audiences. We have a parent support group as well as a couple support group. Our resource coordinators do one-on-one consultations with community members, offering our wide range of information and referrals. We offer medical referrals, mental health referrals, legal referrals. So anything that we don't have in-house, our resource coordinators are able to connect you to those resources externally. They're also in the schools, attending school meetings, helping with items like IEPs, seizure action plans, and accommodations. We offer mental and behavioral health programs that I'll get to in a few later slides. We offer educational conferences all throughout the year. We offer these regionally, but we have also been hosting them virtually as well. So we have been tailoring some of them to specific audiences, such as our adult epilepsy conference, our pediatric epilepsy conference. Later in the spring, we'll be hosting our women in epilepsy conference. But just a week and a few days away, we have our annual epilepsy education conference, which is our biggest and most robust program of the year. But again, I'll get to that in a few slides with more details. We also offer webinars all throughout the year, similar to this evening, that you're able to tune into virtually and further your epilepsy education on various topics as they pertain to you. We host a wide range of community building and awareness raising events. We do 4 regional Walk to End Epilepsy events throughout the year. We have our annual Goff Invitational, our Mardi Gras Gala, all great ways to come together as a community, celebrate a common bond, and raise critical funds and awareness for our local epilepsy community. We offer youth, young adult, and adult services, really any age, any stage of your journey with epilepsy. We have programs and services that are customly built to you and your needs. And then some of the best things that we do at the foundation are our retreats and Camp Achieve. So every August, we host our week-long sleepaway camp for children ages 8 to 17 living with epilepsy. It's just the most fantastic, special, magical week of the year. So we have campers living with epilepsy, often meeting other kids with epilepsy for the very first time, building these mutually supportive friendships, getting to participate in all traditional camp activities, and just really creating lifelong memories. It's such an impactful week. We also host our young adult retreat every May for the 18 to 30-year-old crowd living with epilepsy, and then our adult wellness weekend in September. Now, that is not only for individuals living with epilepsy, that's for the 30 and over crowd, but also parents, caretakers, and spouses. So we're really able to dial into our caretaker space and making sure that that our caretakers also have a place where they're able to relax, recharge, and meet others facing similar challenges. So a note on some of the mental health and behavioral health programs that we offer at the foundation. Hopscotch and PACES are 2 of our evidence-based programs. Seamus, who's joining us as our facilitator this evening, is a coach and facilitator for these programs. And they are just fantastic. We receive nothing but positive feedback in how helpful these programs can be for individuals. So Hopscotch is home-based self-management and cognitive training changes lives. It's a bit of a stretch on the acronym, but we love it. A program designed to help people with epilepsy find ways to manage and cope with memory problems. We all know that memory and cognition is a common challenge that our community members face. Hopscotch is a really great way, one-on-one coaching, to build in coping skills and mechanisms to really rise above some of those challenges. PACES is the program of active consumer engagement and self-management, a program designed to increase the medical, psychosocial, and community adjustments of adults with epilepsy. This is a group program and another great one for you to participate in. As mentioned, I wanted to circle back to discuss the annual Epilepsy Education Conference. This is coming up on Saturday, November 5th, so just 1 week away from this Saturday. This is our in-person half-day conference. It's 8:30 to 1 p.m. at the Delaware County Intermediate Unit right in Morton, PA. Really great program planned. We have a keynote speaker followed by a few breakout workshop sessions. Another great way to further your education. meet other community members, and really develop a nice support network. So if you'd like to register or just learn more about the agenda for the conference on Saturday, November 5th, you can go to efepa.org/conferences. How you can be involved. Again, anything that might interest you, any way that you could use support, we have something for you at the EFEPA. We like to say where the doctor's office ends, that's where the work of the Epilepsy Foundation begins. We're really here to support you and your family, and we'd love to have you involved in any way that you'd like to be. A great way is to raise awareness and share your story. I hope that you know that this November, every November, is National Epilepsy Awareness Month. It's our time to use our voices, to use our social media platforms, to talk about epilepsy, to share stats and figures, to share our stories. So we encourage you to do that and be your own advocate, and to be advocates for others who maybe don't feel comfortable using their voice. As mentioned, our resource coordinators are here to lead seizure recognition and first aid trainings. If you have a child with epilepsy, please reach out to us. We'll get a training set up in your child's school. We can lead our trainings virtually. We can come in person. Same thing in the workplace. We love coming into corporations and leading these for corporate teams. Attend and fundraise for the EFEPA. We just had our 2 walks in Northeast PA and Lancaster in October. We have 2 more coming up in June in the Lehigh Valley in Philadelphia. We have our annual Mardi Gras Gala coming up in February. All great ways to come out, build community, and meet others living with epilepsy. If you visit our website, efepa.org, you can find out about everything we have upcoming. You can sign up for our e-newsletter that goes out monthly that will give you updates of everything upcoming. And another great way to be involved is to follow us on social media. So on Facebook, we are Epilepsy Foundation Eastern PA. On Instagram and Twitter, you can find us by searching @EFEPA. Again, heading into November, it's a great time to follow along. We post on social media very, very frequently during November, and it's a great way for you just to be able to share the facts and stats and figures that we're sharing all throughout the month to help boost that engagement and help us reach more people. I wanted to take a quick moment to thank our generous sponsors who make our programs, such as our conference this evening, and so much of our work possible. So first and foremost, I wanted to thank our conference series sponsors who sponsored all of our conferences that we have hosted and will host throughout the year. So a big thank you to Marinus and UCB. And then I wanted to give a big thank you to our webinar sponsors who hosted this virtual program this evening. A big thank you to Geisinger and Jazz Pharmaceuticals. And with that, I would like to introduce my colleague and our Greater Philadelphia Resource Coordinator, Seamus Morgan.
Perfect. Thank you so much, Missy, and good evening, everyone. I'm so glad to be here with all of you tonight, and I'll be helping facilitate tonight's conference, and we have a couple great speakers lined up. This is just tonight's schedule real quick. We'll get started with our first speaker in just a minute. It will be updates in epilepsy, latest treatments, and will be followed by Q&A. And then after that, we will have updates in epilepsy of surgical options, followed by a Q&A session as well, too. So it is my pleasure to introduce our first speaker of the night, and that is Dr. Saurabh Sinha. Dr. Sinha is a professor of clinical neurology at the University of Pennsylvania, director of EEG laboratories at Penn Medicine, and program director for the Epilepsy Fellowship. Dr. Sinha received his BS in biomedical engineering at the Johns Hopkins University. He then completed his MD and PhD at Baylor College of Medicine. He subsequently completed his residency in neurology and fellowships in clinical neurophysiology and advanced epilepsy at Johns Hopkins University. He was the medical director of the epilepsy program at Sinai Hospital in Baltimore for 4 years prior to joining the faculty at Duke University in 2009, rising to the rank of associate professor with tenure. While at Duke, he served in several roles, including medical director of Duke Center for complex epilepsy, Vice Chair for Education and Neurology, Program Director of the Neurology Residency, and Program Director of Clinical Neurophysiology and Epilepsy Fellowships. His professional interests include epilepsy surgery, ICU, EEG monitoring, and neurology education. His research focuses on evaluation of patients for epilepsy surgery, ICU, EEG monitoring techniques, and biomarkers for epilepsy. So thank you so much, Dr. Sinha, for joining us tonight. And at this time, I will hand it over to you.
Thank you, Seamus. Thanks, Nasir. I really appreciate the chance to do this. And I honestly, also want to just state that I really appreciate how nice it is to be in an area where the Epilepsy Foundation is as active as it is here. It's, I think Missy said it in one of her slides, but there's so much more to epilepsy than what is done in the doctor's office as far as managing it and living with it, that it's really nice to have a partner like the Epilepsy Foundation to work with. Dr. Wu, who's the second speaker, is going to really talk about surgical options for epilepsy and how those have changed or evolved over what's coming up in that area. I'm going to talk a little bit about the medical side. Just a quick slide about disclosures. I don't think any of these really impact what I'm going to say here, but just to be forthright, I have worked with some companies for research related to epilepsy medications and devices, and also consulted for some in the past. And I also have some memberships in societies that I work with that are related to epilepsy and neurophysiology. In the past, when when we've generally talked about this type of lecture, a lot of times updates in treatment, really, we look at this list of medications that are available in the US, and you go back a little bit from the time where you're at, and you kind of talk about the most recent medications. And I am going to do that. I'm going to talk about 4 or 5 of the newer medications that have come out and talk a little about where they fit in into our algorithm and how we use them. But I really thought we'd kind of take a look, a little broader look at how the medical management of epilepsy has changed and kind of the things that are impacting it over the last several years, and perhaps the direction that things are going in the future. So with that in mind, this is kind of the outline of the talk. I was going to talk a little bit about some changes that have happened and are slowly coming up as far as terminology, the words we use to talk about seizures and seizure medications. I'm going to also talk a little bit about the indication. So, how drugs are approved or applied. There's been some changes in that process and how people look at that. So I'm going to talk a little bit about that. Then, as promised, I will get to some of the newer medications and talk a little bit about them. And then lastly, when you look at that last slide where we have just this ever-growing number of medications, by some counts, we're up to 45. Not all of these are currently available. Some of them came and went. Some of them are not necessarily available currently in the US, but we're up to at least 30 or so medications now. So I thought we'd spend a little bit of time talking about how you approach picking medications in a world where you have, fortunately, so many options now. So with that in mind, let's jump right in. A little bit on terminology. So, I think there's a big movement that's been going on now for about 5 or 6 years to really change how we label seizures and also label epilepsy. But I'm going to talk a little bit about the seizures. And this is an effort that's been put together by a group called the International League Against Epilepsy. It's the kind of the international umbrella organization for physicians and others who work with epilepsy and epilepsy research and critical care patients. And for example, the American Epilepsy Society is a member of that group, and they have been responsible for the terminology that we use to talk about seizures. And there's been, since about 2015 or so, there's been a major effort to kind of update the words we use. And this is really a schematic of what people are trying to go towards now. For those of us who are of a certain age, it's hard to just change the words we use. So you'll still see us slipping back into that. But I think more and more often, when you talk to physicians, when you talk to others about seizures and epilepsy, you'll see this terminology. So we still talk about seizures as being what we call focal or generalized. And this means that at the very beginning of the seizure is the abnormal activity starting off in a small area of the brain, or is it starting off in the whole brain kind of all at once? And this is the same, difference that we used in the past. But what the new terminology adds is that it adds this group called unknown onset, because the reality is there are many seizure types where we have a tough time knowing which one of these we really are talking about. So that's one difference, is that we added this unknown onset category. Under each, we still talk about seizures that mainly involve movement or motor component, and seizures that involve things that are not movement, sensations or feelings or changes in how someone is, how aware they are, those kind of things. So we still have that. Then the next difference that really happened was, in the past, we always talked about what we call simple partial or complex partial seizures. Simple being the person was aware and knew what was going on, and complex meaning that there was some level of confusion, all the way to being completely unaware of what's going on around them. And what they did was they added this group called unknown awareness, because again, it can be hard to tell in advance which one someone has. So that's going to change. And then we still allow for seizures that start as focal, but then go on to becoming generalized. So, so this has been kind of a change in the schematic. As with everything, it's more complicated than that. They actually have a bunch of subcategories depending on the type of seizures, the type of symptoms, and that kind of thing. But the main difference is we've gone from simple partial, complex partial, generalized tonic-clonic, absence, to kind of a more multi-tiered system. So just as an example, in the old terminology, we talked about absence or petit mal seizures. Now we'll call them a generalized absence. Probably the most common seizure type that we see, at least in adults and even kids, is something called a complex partial seizure. If you're really old, you would call it a psychomotor seizure. Now, instead, we would call it a focal with impaired awareness. If you had a simple partial seizure, which some people sometimes call an aura, we would call that a focal aware seizure. So just some changes in the words we're using. And I think, the main difference here really is we changed the words because the old system had some gaps in it, that it was hard for people to necessarily look at the same seizure or hear about the same seizure, and people might call it slightly different things because there was some overlap or some lack of clarity. So this is there. Again, this is not something that's really going to impact how someone manages a seizure directly as much, but it does impact necessarily how we talk about them. So if you haven't already, you'll start hearing these terms being used by physicians and others to talk about seizures rather than the old terminology. So that's one change just worth knowing about. The other one, which is kind of one of those changes that is really been subtle, but has been kind of afoot for a while, which is changing what we call our medications. So, most of us grew up calling these medications anti-epileptic drugs, or AEDs. And that's a term we use, and you'll still see many of us kind of use that terminology. And every time I give a presentation, I have to kind of go through and find the slides that still use AED and change them to ASM. But both the ILAE and others have been talking for a while now that anti-epileptic just has a connotation that is incorrect. It somehow implies that our medications actually treat epilepsy or fix epilepsy. And the reality is our medications are ones that control seizures. So they, while you're taking them, they will hopefully control the seizure or stop the seizures from happening, but they don't really change the underlying process. And if the tendency for seizures is still there and you stop the medication, unfortunately, the seizures return. So people have argued that for this reason, we should really use the word anti-seizure medication. So you'll see that more and more commonly, is that we talk about anti-seizure medications rather than anti-epileptic drugs. The hopeful part of me says that part of the reason why we're doing this now is that we are perhaps on the verge, maybe in the next few years, maybe in the next decade or so, of actually having true drugs that are anti-epileptic, meaning drugs that somehow could be given for a short period of time and actually treat the epilepsy, treat that underlying tendency, so that after you take the medication for a while, perhaps that tendency in a perfect world goes away, but at least goes down. So I think, that's something that people have been thinking about and working on for a long time. I wish I could tell you that we're ready to be there right now. We're not quite there, but I think people are thinking that it's sometimes going to happen, and that's why this is maybe a better terminology, but also, just that the old terminology was a little bit unclear and a little bit misleading, because the drugs are anti-seizure and not really anti-epileptic. So just a couple of things about terminology. Another big thing that I think is a little bit worth knowing about, and this will tie into the medications that I'm going to talk about, is that there's been a change in how the FDA, which approves all medications and other treatments for diseases, including epilepsy, has been looking at medication. So there's an update on what we call indication. So anytime a drug is approved, it's approved for a certain indication, to treat a certain condition or to be used in a certain way. And a lot of that process dictates a lot of how medications come to the market and how they're available. So in the past, the FDA really talked about approving medications for certain seizure types. They had medications that were approved for focal onset. They had medications that were approved for generalized onset. You could also get them from myoclonic, and there was really one drug approved specifically for absence. In addition to those seizure types, which was the vast majority of indications, there was at least one syndrome that we'll talk a little bit about called Lennox-Gastaut syndrome. That was also an indication that certain drugs were approved for, and that's been the case at least now since for at least about 20, 25 years, that there were drugs that were specifically approved for this condition, although we'll talk a little bit about why that's the case. And then lastly, there were a handful of drugs, really old drugs, that actually had an indication for treatment of status epilepticus. The way the FDA rules have changed over time, where you have to do a trial where you compare your medication to a placebo, has really meant that there probably will not be another drug approved for status epilepticus anytime in the near future, just because it's hard to do a trial where you give someone who's having those recurrent seizures or those really long seizures a placebo. So, but these were the indications that were traditionally used. Now, in over the last 5 years or so, there's been really a couple of big changes. One is that in the past, and if you've been in this field for a while, including even as a patient, you'll know that in the past, the FDA often approved drugs as what we call an adjunctive therapy, meaning that it was meant as an add-on. And that was really left over from the fact that that's how the drugs were tested. Again, that whole idea of you had to do a placebo-controlled trial. And if you have a patient with epilepsy, obviously it wasn't considered ethical to give them either a medication or a placebo. So it was always done that you took patients who were already taking a medication and were still having seizures, unfortunately, and then they got added on to their medications, either a drug or a placebo. So a lot of times medications were approved for adjunctive therapy. Now, no one ever believed that there were drugs that were only effective when added on to another drug. We always thought that they could be used alone, but in the past, you had to go through a lot of steps to prove that. But as of about 4 or 5 years ago, the FDA kind of removed that requirement. And now if a drug is proven effective for seizures, even in a trial where it was an adjunctive drug, it gets an indication for that condition. So you will no longer see medications that are specifically labeled as adjunctive. The other thing that's really changed is in the past, when medications were approved, they were approved for the age group that you tested them in. So most drugs got approved for adults above the age of 18, sometimes above the age of 15. And then slowly the companies had to go back and do trials in pediatric populations and that kind of thing to get the age allowed lower. The FDA said that's probably not necessary. And now they don't have to do that trial. They just have to kind of measure how the drug is absorbed in a younger population, and they can get that indication. So, that's been a major simplification in how drugs are approved. And it makes so much sense that it always amazes you that the government agreed to do it. But it makes a lot of sense, and it's wonderful. The other thing that's really changed is that there are some new indications that are now being looked at. We talked a little bit about Lennox-Gastaut, but there are a couple of other rare conditions for types of epilepsy that now are also conditions for which a drug can be specifically approved. And that includes something called Dravet syndrome, and we'll talk a little bit about that. And also tuberous sclerosis, which is a disease that has many manifestations, but often includes seizures that are very hard to control. The other indication that's really come about is that there are now some medications that are specifically approved for what are called acute repetitive seizures. So it's not quite status, but it's when someone is having one seizure and then another seizure and then another seizure over a relatively short period of time. And we'll talk about what short means in a second. But these are kind of new indications. And actually seeing one of the slides that Missy showed reminded me that there's also actually recently a drug approved for a condition called CDKL5, which is a gene mutation that causes a form of epilepsy in children. But again, these are out there, and it is a major difference in how we're looking at these. Just to kind of, because this is going to come up in several times when we talk about the medications, just to talk a little bit about these conditions. And again, for many of you, this will be stuff that you're familiar with, but these conditions that I mentioned that are now syndromes for which the FDA has approved some drugs specifically for them are what have traditionally been called orphan diseases or orphan drugs. There's an official definition. The official definition is a disease which at any given time, there are fewer than 200,000 people in the US that are affected by it, okay? And so Lennox-Gastaut syndrome, Dravet are examples of this. And the reason that distinction is important is that the FDA understands that it might be, there might be less interest from drug companies to specifically develop drugs for that because there's a smaller number of people that will use that medication. So they allow these companies to have some advantages in developing these kind of drugs. But Lennox-Gastaut syndrome is something that is actually not uncommon, but still a fairly rare condition. It comprises really three things. These patients tend to have fairly hard to control seizures, and they have multiple seizure types. Kind of the most classic one is something called a tonic or an atonic seizure. It looks a little bit like what you, the EEG during that looks a little bit like this. You see a big discharge and you see a flattening and what people have called generalized proximal fast activity, but basically the patient stiffens and sometimes depending on what they are doing at that moment, they might fall to the ground. In addition to that, they often have something called atypical absence, but they can also have the plain old generalized tonic-clonic or myoclonic or even focal partial seizures. In addition to that, they have a certain pattern on the EEG that's sometimes hard to find, but if you look hard enough, you'll often see it. You'll certainly see this pattern, this GPFA that I mentioned, but you'll also see what's called atypical absence or slow spike and wave on EEG, where you see this big generalized discharge that looks like, looks almost like a heart rhythm, but it's an EEG rhythm, and it's kind of at a slower frequency than what we've seen some other patients with epilepsy. And the last feature of Lennox-Gastaut syndrome is something called static encephalopathy. That's just a fancy way of saying that they have some level of cognitive impairment. The static part usually means that it's something that once it's there, it stays stable over time. It doesn't necessarily get worse. It doesn't get better, but it doesn't necessarily get worse. Lennox-Gastaut syndrome is probably not a single disease. It probably is multiple things that kind of have the final same manifestations. So things like certain birth defects or what we call congenital malformations, where certain parts of the brain developed in an abnormal way can cause it. Brain injury can cause it. Certain genetic disorders, like for example, I mentioned tuberous sclerosis, that can be associated with Lennox-Gastaut syndrome. The treatment for this, it's been one of the hardest to treat conditions for a long time. And so basically we throw everything, including the kitchen sink, at this in some patients. Although some patients, like with all of epilepsy, there's a range, and some patients can actually be, have reasonable control of their seizures with this. But there are some medications going all the way back to medicines like Tegretol that have specifically been approved for this, in addition to their other things. But there are, we'll talk about Epidiolex, we'll talk about fenfluramine, we'll talk about stiripentol, which are new drugs that are approved for this indication. So Lennox-Gastaut as a condition has been around, as a condition for which drugs are approved, has been around for a while. A relatively newer one, again, not a newer condition, but one for which specific medications being approved is relatively new, is something called Dravet syndrome. This is also a very severe form of epilepsy. It's genetic. Lennox-Gastaut typically is not thought of as being genetic, or at least there are many different varieties, but Dravet is genetic. It used to be called myoclonic epilepsy of infancy. It's most often associated with a particular gene called SCN1A, which is a sodium channel gene. Not too much know about that, but just that most patients who have this condition have a mutation in genes that we know about, and most commonly the sodium channel gene. It is a relatively rare condition. About 1 in 20 to 40,000 people with epilepsy have this. Sorry, 1 in 20 to 40,000 people have this. Clinical, it's mainly seizures that start very early in life, often in the first year. First one is often with a high fever. The seizures tend to be long. They often have status epilepticus, or just a really, really long seizure. Seizure types include, again, almost all the range of types of seizures we talk about. They sometimes are photosensitive, meaning flashing lights and those kind of things can trigger them. They often start out before the seizures start. You have an infant who's developing normally, but once the seizure starts, they tend to regress and lose milestones, including sometimes have difficulty with their motor tone and those kind of things. Treatment for this, I mean, we've known for a long time that certain drugs, the ones that work on that sodium channel, are sometimes things to avoid. But specific treatments for this have been relatively new. So we'll talk about stiripentol, we'll talk about fenfluramine, we'll talk about CBD. Again, it's not necessarily that these drugs are specifically meant for this condition and don't work for anything else, but they were approved for this condition. Okay. The last one that I just want to mention is, as a new indication, is this idea of seizure clusters or acute repetitive seizures. Now, again, this is not a new phenomenon. We've known for a long time that there are patients who, when they have one seizure, they're very likely to have another one soon thereafter, whether it's minutes later or hours later. But you know that it's typically that many times they're not just going to have one seizure that day. So this thing, we've called them seizure clusters or acute repetitive seizures. There's really not an agreed upon definition for what that means, but somewhere between more than a couple in 6 hours or more than 2 or 3 in 24 hours, people would call a cluster. I kind of think of it more as more than you typically have, or this. So, and the reason this definition kind of becomes important now is that we actually do have some new medications that are specifically intended to treat seizure clusters or acute repetitive seizures. So with that, I'm going to kind of jump into the seizure medications. Okay, I've never been able to get rid of this slide because I like it so much. And this just kind of thinking a little bit about our medication. So, just in a very simplistic way, I think about epilepsy like this. I think about the brain as kind of being a little teeter-totter, where the brain activity is kind of a balance between things that excite nerve cells and things that kind of inhibit them or turn them down. And this little triangle in the teeter-totter is what we call excitability. It's how much the nerve cells want to get excited and fire. And in the brain that's not having seizures, all this is balanced. In a brain that's having seizures, whether it is because of more excitation, less inhibition, or changes in excitability, this teeter-totter goes off and you have seizures. Okay. The medications we have kind of, if you will, somehow try to reset this balance. They can either decrease excitation, they can increase inhibition, or they can change excitability. And this kind of implies that we know exactly how all of our drugs work. It doesn't, but it's kind of just generally with the blonde. But I mean, all these drugs are somehow trying to reset that balance. In a little bit more detail, and again, I apologize for this slide, it's a little too much, but just, we do have some idea about where our different medications work. This is what's called a synapse. This is the connection between one nerve cell to the other. And a lot of our drugs work by changing how that connection works. They can work by, on something called sodium channels. They can work on calcium channels. They can work on things called GABA receptors, AMPA receptors. Just know that there are many, many different targets for the brain, for the medications in the brain, and that list of targets has been growing. And that's been one of the exciting things about some of the new drugs that have come out, is that they are not hitting the same parts of the nerve cell or part of this machinery as some of the older drugs that we have. And while that doesn't necessarily mean that they're going to be a better drug, it just sometimes gives us hope that perhaps they will help some people that other drugs that we have won't help. So, anytime a drug with a new mechanism or a new way of working comes out, it always gets me a little bit more excited than I might be otherwise. So with that in mind, just let me kind of jump into a few of the drugs. And again, none of these are brand new, but I think some of them are new enough. One that probably, it certainly isn't brand new and had so much excitement about it that I think probably most people heard of it, is what's called Epidiolex or cannabidiol oral solution. This is the extract from the marijuana plant, but not the one that gets you high, which is THC, but instead another component of that. It has been approved by the FDA at this point for all three of the conditions I talked about: Lennox-Gastaut syndrome, Dravet syndrome, and also tuberous sclerosis complex. Unlike the mechanism for this, we actually don't fully understand. We know it binds to something called a CBD receptor in the brain, and it may affect this thing called glutamate, which is one of the excitatory messengers in the brain, but we don't fully know it. But the main thing is it's a different target than a lot of other medications we talked about. It's a medication that we start at a certain dose and work up gradually. One of the changes that has happened with this medication in the last year or so is that I think we have expanded how high we can go on the dosage. So when it first came out, the FDA recommended, and the approval was that you should go up to about 10 milligrams per kilogram. So, for the average adult, that might be 300 or 400 milligrams twice a day at most. But as they have studied the medication further and gotten more comfortable with it, and as part of their studies on tuberous sclerosis, they recognize that you could actually often go much higher and still get benefit from it. So actually, for tuberous sclerosis, the recommended dose is all the way up to 25 milligrams per kilogram, which again, if you're talking about the average person, we're talking about somewhere in the range of almost 800 or milligrams twice a day. So much higher than what we've used in the past. It doesn't mean that everyone should go that high, but just something to keep in mind. The other thing I really like to kind of point out about this medication is that it is a medication. A lot of people would like to believe that because it's somehow a natural coming from a plant, that it is no longer a medication and it's somehow healthier or safer. And what I'd like to point out is that when you take a chemical from a plant and you crush it up and purify it and give it in a huge dose, it's probably not very natural anymore, but it's an effective drug, but it does have drug interactions. It has some chance of affecting the liver, especially in patients who are also taking a medication called Depakote or divalproex. But it's overall a very safe and clean drug, and something that certainly has a role. I just put this up here for for completeness, but this is how we study these drugs. When, again, as I mentioned, we always give a placebo and we always give the medication and compare the response. And this is in the patients with Lennox-Gastaut. The white bars are the placebo, and you can see that most of the patients had a fairly, who got the placebo had little change in their seizures. Some did have a bigger change, but the black bars, which was a higher dose of the Epidiolex, you can see that that there were definitely more patients who had a bigger response over here. Similarly, this is the study with Dravet, just showing you again that the placebo, most patients didn't have much of a change in their seizures, whereas there was a change towards the upper side here. Again, the numbers aren't that important, but just to show how we look at this. It is, as I mentioned to you about the liver injury, but the more common side effects are really, like all the seizure medications, it can make some people sleepy or tired. Kind of an unusual side effect that we don't see in everyone, but certainly in some people, it gives some people diarrhea, but usually nothing that is severe, and often gets better with time. And if it doesn't, you take the medication away, it goes away. So just to kind of jump to some of the other medications, there's a medicine that is now about a couple of years old now, called cenobamate or Xcopri. It is approved for partial onset or focal seizures, and it also kind of more the traditional approval. The mechanism we don't really know. We think it probably affects sodium channels and also GABA receptors, so it does multiple things. You have to start it very slowly, and I'll tell you why in a second. We usually go up to about 200 milligrams, sometimes higher. It's a once-a-day medication. It does have several drug interactions, so something we're always careful about, because often patients who are taking this kind of medication are on other seizure medications and perhaps other medications. But one of the things that kind of made this drug particularly exciting, again, this is the trials, and we don't know if it's going to play out this way in the real world, but is that in the trials, it really performed well. I mean, this is the group that in the trial had a 75 to 100% reduction in their seizures. And you can see, that was almost a 40%, which is, again, just for typical what we see in these trials was quite a good number. Now, again, this is a trial, it's only for 12 weeks, but it was pretty exciting. The thing that made it a little bit less, a little longer to come on the market is that there were a small number of people that developed something called multi-organ hypersensitivity or sensitivity or DRESS syndrome. This is certainly a rash, but also liver and cell counts and other issues. It can be quite severe. It can even be deadly. With slower titration, meaning starting the medication very gradually, it seems to be much, much less common. And people think it's probably much safer that way, but it does take a while to get on it. Side effects are similar to a lot of medications, sleepiness, dizziness, gait problems, but it's there. I just want to mention two other newer drugs quickly. Actually, I apologize, four there. So one is a drug called fenfluramine, Fintepla. This used to be part of Fen-Phen, but the diet drug, it's approved now for both Dravet and for Lennox-Gastaut. It has a completely different mechanism. We think it binds to something called serotonin receptors, which is different than all the other drugs we have. Its dosage is you can see there. It binds to, it does have interactions to worry about. The big thing about it that's a concern is that at least in some studies, it's been associated with some heart problems, some changes to the heart valves, that kind of thing. So as part of this medication, we do get ultrasounds of the heart fairly regularly. But the more common issues are things like sleepiness, sometimes changes in bowel habits and balance problems. But again, a really new and fairly exciting drug that has to be used carefully, but is there now. Another drug that is kind of new to the epilepsy world, but or new to the U.S., but this one has actually been around for a while, is a drug called stiripentol. This is right now only approved for Dravet syndrome, and specifically it's approved for Dravet syndrome in patients who are taking clobazam, which is Onfi. And the reason is that's the way it was studied, okay? And we think at least some of the benefit may be because it actually increases the clobazam level, but you can see from the same type of graph where in this case, the blue is placebo and the orange is the medication. You can see that there's just a huge response to this medication. So we think there's probably more to it than just the clobazam thing, but it's there. And again, this drug right now is only approved for Dravet, but it'll probably get some other indications. We don't think there's a reason to think that it's only going to work for that condition, but that's where it's approved. It can cause some problems, including drop in white counts and platelet counts, and it can cause some problems like sleepiness and those kind of things. Just the last two drugs I want to I'm going to skip this one just in the interest of time. It's not new, but it's a medication that's specifically meant for tuberous sclerosis. The two that I do want to spend a little bit of time with is there is now something called Nasolam, which is we were talking about acute repetitive seizures, and this is a nasal spray that contains a medicine called midazolam, and it is indicated specifically for the acute treatment of intermittent, meaning it's not a continuous seizure, but typical seizures that are happening frequently and more often than the usual seizure pattern for the patient. Okay, it is actually a medicine that is closely related to things like Ativan or lorazepam or Klonopin or clonazepam, same class, but it's just given a different way. So it comes in a little spray like this. That's a single dose, and basically it goes in the nostril, and you push the little button, and it sprays inside. and it's a single 5 milligram dose. You can give a second dose after 10 minutes if needed, but basically it's meant to treat a seizure cluster or repetitive seizures, and it's a big change for us because until recently there were very few medicines that you could give to someone who is either having a seizure or just had a seizure and is still sleepy or confused at home. Really the only option if they couldn't swallow a pill was a medicine called Diastat, which was a gel of a medicine called diazepam that had to be given rectally, meaning in the back end. And while it was effective, it was kind of a little slow to work and also not ideal as far as how it was given. So the fact that there's now these kind of medications has really been a big change in how we think about this. There's a second drug that came recently that is also in the same category as far as a nasal spray meant for these acute repetitive seizures. This one actually has a medicine called diazepam in it, which is again that same benzodiazepine category. It's in the same, it's actually the same drug as, or same chemical that's in the Diastat, the rectal gel I was mentioning, but it's now a nasal spray. And this one, the main difference is that it actually is approved down to age 6, and it comes in multiple sizes from 5 milligrams up to 20 milligrams. And again, both of these are effective drugs. This has been a big change for the adult epilepsy doctors because a lot of us struggled in the past to figure out how to treat patients' seizures at home who were having a long seizure or multiple seizures because there just weren't great options that a lot of people were willing to take. And having these has really changed that. So something that's there. I was going to spend a few moments on medication selection, but I think in the interest of time, I'm going to stop here and just say that, there are real changes happening in how we medically manage seizures. Maybe I'll jump to this last slide, which is just kind of how I think about these medications. And again, don't take this for too much other than this is just when I've tried to teach this to my residents, this is kind of what I came up with as far as how I think through these medications. But what I would really like to kind of leave people with is that, we have a lot of medication options now, 30 or more. And that what that means is that for the patient, there is a lot of different ways that they can go. And at least in my experience, it's the rare patient where I really think this one drug is the right drug for this patient at this time. It's usually that there are several drugs that could be equally good or equally appropriate. And so it really should be a discussion between you and your doctor or between the patient and their doctor to figure out what is the right medication to try. And there are always going to be pluses and minuses to different options. And then you pick. So that's one. The other thing is that because we have so many options now and so many different mechanisms and all that, it's important to kind of think about that as if someone is unsuccessful with one medication, where do we go next? And sometimes thinking about picking a medication that works in a different way or in a different part of the nerve cell is something worth thinking about. So I certainly spend some time thinking about that. If I'm moving from one medication to another, is that am I picking something that is more likely to work or that is at least working in a different way? And then the last thing I'll just say is, with the arrival on the market of the 2 drugs that I mentioned for the repetitive seizures and the fact that there are other ones that are probably going to be available soon, it really is important. It was always important, but it's even more important now for patients to really talk to their physician about what do I do if I have a seizure at home? And certainly, if it's a single seizure, it might be one plan, but what do I do if I have a long seizure or severe seizure? Again, the answer is not always to spray something up your nose, but the main thing is to have that discussion because there are options now that should be thought about. And so with that, I will stop. Thank you.
Perfect. Thank you so much, Dr. Sinha. I really appreciate that presentation, and it was a lot of great information. We do have some questions in the chat box for you, and I will take some time to read those aloud. The first one asks, as I scroll up, are you able to determine the classifications between Lennox-Gastaut syndrome and Dravet syndrome?
Fortunately, so Dravet is relatively easy to diagnose if you look for it, in the sense that there actually are blood gene tests that can be done to look for those mutations. So with Dravet, we can often have a very specific diagnosis. Lennox-Gastaut is a little bit harder in the sense that the hallmarks that I mentioned, especially that EEG, isn't always available at the time that you're having. So at some point during the course of the disease, they often have those EEG characteristics, but it's not always available at the moment. So especially by the time they get to be an adult, it is often very hard to firmly say that this is what they have. In an adult, you can still diagnose Dravet fairly accurately if you go looking for it. I think that's part of it, is that in the past, we haven't always gone looking for it because the gene tests weren't easily available and because there were not necessarily specific medications for them. But now that there are, it's still a fairly easy condition to diagnose if people go looking for it.
Perfect. Thank you so much. The next question we have is, what is your viewpoint on 2 failed medications? Does that make you drug resistant and now only seek surgical options?
So, I think it's a great question. I'm sure Dr. Wu is going to talk a little bit about some of that, but I do think that there's very good data to suggest that if you have tried 2 medications, and it's important to know that we always say 2 adequate medication trials, meaning that it has to be a medication that is right for the condition and the type of seizures that someone has, and it has to be something that was tried at a high enough dose to be effective. So if someone tries a low dose, then it causes some bad side effect or problem, and they stop taking it, I don't count that as a failure. But if you fail 2 medications that are appropriate and at a high enough dose, then that's certainly at least time to start talking about surgery. Now, it's important to keep in mind that some people still do have real benefit from that 3rd drug or even the 10th drug. So it doesn't mean that you should stop thinking about medications altogether and surgery is your only hope. It just means that if you're at the point where you've tried 2 medications, you at least should be seeing someone like me or Dr. Wu or one of his colleagues, and at least talking about, hey, what are my other options? But I never think that at least trying some other medications is inappropriate. It just means that you should at least start talking to people about what else is out there. But I don't think it's that if you fail 2, you have to have surgery, or surgery is your only hope. It's just that it's time to broaden what you're looking for rather than just another medication.
Great, thank you very much. The next question we have is someone asking about tonic-clonic seizures, and we know that there are multiple medications out there, including the new one, Xcopri, but it may not work for everyone. Are you able to give like a brief answer if there are any like upcoming medications or any drugs being researched currently?
Yeah, I mean, so there are, tonic-clonic seizures are kind of really come in two flavors. There are ones that are what we call generalized onset, meaning that they started off as a seizure that was in the brain all from the get-go. And then there are ones that are focal onset that then started focally and then spread into the whole brain. There really hasn't been any good evidence to say that there are medicines that are particularly good for tonic-clonic versus other types. There's some that we think are not good. A classic example is something called ethosuximide, which is a drug for abscesses. But it's hard to say that there are any drugs that are specifically meant for that condition. There's some drugs that have shown that perhaps they had better results for that condition than some others, but that data is kind of not great data. So I'll say almost any of the drugs, as long as you have the right type of seizure onset, meaning focal or generalized, many of these different drugs can work for that seizure type.
Perfect. Thank you so much. And one other question that we have that one community member has asked: are there any major psychiatric side effects that you know of when people are taking the medication Keppra?
Yeah, so Keppra, and really, and Keppra probably is the one that gets the most attention, and with good reason. But all of our medications are affecting the brain. Okay, and I think we all, now hopefully most of us recognize and appreciate that a lot of psychiatric conditions, all psychiatric conditions also are rising in the brain. So a lot of our medications can affect them, both in a negative way and a positive way. Keppra has traditionally been one that, when it has an effect, it tends to be a negative effect. So we often, not often, but maybe as many as 1 in 10 people will notice problems with mood, meaning depressed mood or sadness, that kind of thing. You can also actually, in some cases, not commonly, but you can see what people have called psychosis, things like hallucinations and those kind of things. Again, it's not common, but it's there, and it's something that we certainly watch out for. But really, I would say that for any seizure medication, it's worthwhile for both the patient and the physician to pay attention to whether or not it has any effect on their mood or behavior. And just to complete that thought, there are also some medications that we use for seizures that actually have some potential positive or beneficial effects for certain types of psychiatric problems. So sometimes when we are thinking about which medication to use for a particular patient, sometimes that enters into the discussion, is that if I have a patient with significant anxiety or those kind of things, there are certain medicines that I might pick over others because they might have a beneficial effect for their anxiety beyond helping their seizures. So it can go both ways. But yeah, Keppra, we certainly sometimes see negative side effects like that, but most people don't have that problem, but some do.
Perfect. Thank you very much. And looks like we have time for one more question. And the question we have is, can diazepam nasal spray be used for generalized tonic-clonic seizures?
It can. So, the FDA approvals are always based on how things are studied, but the reality is most of us are now giving these medications to patients, not only to use if they have multiple seizures in a short period of time, but also if they have a seizure that is longer than average. Now, the reality is most seizures last 30 seconds, maybe a minute and a half. And even these nasal sprays aren't necessarily going to work that fast, okay? But what most of my patients who have a risk for convulsive seizure will tell them is that if a seizure goes on for more than 2 minutes or so, and again, this is something to individualize for each patient and discuss with your doctor, that's when they could use that, and potentially it could prevent that from being a longer seizure. Okay, so we will sometimes use it for those kind of things. Again, that's not how it was tested, that's not how it was approved, but also just kind of thinking about it, there's really no reason why it couldn't work that way. And important to keep in mind is that these drugs are drugs that the body can get used to. So it's important that these drugs not be used on a regular basis, because after a while, they just aren't effective anymore in that way. Again, it's important to kind of talk with your doctor about this and figure out when it makes sense to have a rescue medication like that and what should be the trigger for using it. It shouldn't necessarily be something that becomes used on a daily, or certainly not even a weekly basis kind of thing.
Okay, great. Thank you so much for all your answers and tonight's presentation, Dr. Sinha. We really appreciate you being one of our guest speakers tonight, and you provided a lot of great educational information to our community.
Happy to do it. Thank you.
Absolutely. So at this time, everyone, I am going to move on and introduce our next speaker. We have a great next speaker that I am very excited to introduce, and that is Dr. Chang Wu. And Dr. Wu is currently an associate professor of neurosurgery and radiology and division chief of the Division of Epilepsy and Neuromodulation Neurosurgery at the Vicky and Jack Farber Institute for Neuroscience at Thomas Jefferson University. He also serves as the clinical director of the Jefferson Integrated Magnetic Resonance Imaging Center. Dr. Wu's research is focused on advanced brain imaging, specifically magnetic resonance imaging, also MRI-based techniques of blood oxygen level dependent imaging and diffusion imaging that can be used to analyze functional and structural networks of the human brain. In his work, he continues to explore the widespread networks involved in epilepsy with the goal of improve medical and surgical outcomes. So thank you so much for joining us tonight, Dr. Wu, and I will hand it over to you.
Great. Thanks, Seamus. Can everybody hear me okay?
Yes, we can.
Okay, let me go ahead and try to share my screen here. That's is part of it right now. Hold on. That's not working well. Give me a second.
Of course.
How about if I do? How about that? Is that better?
That's perfect. Yeah.
Right. All right. Good evening, everybody. Thanks for joining us. Thanks for the introduction, Seamus. Again, my name is Chen Wu. I'm a neurosurgeon at Thomas Jefferson and division chief there for the stereotactic functional, otherwise known as the epilepsy neuromodulation division. And so I was asked to talk about updates in surgical options for epilepsy today. So let's just dive right into it. These obligatory introduction slides, we all know that epilepsy is very common. It's the fourth most common neurological disorder in the United States. And, I think everybody here knows that it has significant impact and has wide reach to not only patients suffering from epilepsy, but also their families, caregivers, and support system. What we certainly are trying to avoid is not only the morbidity, but mortality associated with epilepsy. And this is why we consider things like surgical intervention very seriously, because overall, when you look at the overall morbidity that's been equated to approximately 10 years of life lost when you look at quality of life associated. But more importantly, and the reason that we, especially as a team at Jefferson, are very aggressive when we think about starting that discussion, at least like Dr. Sinha was saying, at least starting the discussion early, is because we see that mortality rates, the risk of death or dying from a seizure or seizure-related injury, is anywhere from 2 to 5 times higher for those with epilepsy when you compare it directly to age-matched controls in patients without epilepsy. And that's particularly true if you have tonic-clonic seizures or if you have seizures where you lose awareness. Not so much true if you have focal aware seizures. So that being said, what we're getting to is if you can control your seizures with medication, that is probably the best case scenario. But in approximately 20 to 40% of patients, the number I generally have in my head is that about a third of patients will fall into this definition of drug-resistant epilepsy. And so it's been touched on in previously in this webinar by Dr. Sinha and some of the questions that came about. But the definition of drug-resistant epilepsy is a failure of adequate trials, as Dr. Sinha had emphasized, of 2 or more tolerated, appropriately chosen and appropriately used anti-epileptic medications. And if you are not able to achieve seizure freedom with that, then your chances of achieving seizure freedom with a third or subsequent medication is certainly much lower. As you can see in this graph, it's less than 3 or 4%. So keep in mind, the question then comes about that this publication came out more than 20 years ago. It was published in the New England Journal in 2000. So there's a lot of new medications that come about. There's different understanding of epilepsy. Is that affect outcomes? So same group, Drs. Kwan and Brody, did a reanalysis only 4 years ago now in 2018. And unfortunately, even with the advent of new medications with new mechanism of action, it still remains a problem, and that your chances of achieving seizure freedom with a third, fourth, fifth medication, as you can see in this graph at the bottom, become increasing lower to the point where certainly past the fourth and fifth, your chance of seizure freedom are in the order of 1% or less. So, again, it's important to ensure that you're trying the right medication and that it's been an adequate trial and it's not stopped just because of side effects or things like that. But, unfortunately, a lot of times when we see patients have tried 10, 11, 12 medications, and that's certainly getting to the point of redundancy. So certainly I will re-emphasize the idea that just the idea of thinking about surgery, at least in this stage, if you happen to be unfortunate in that falling into the category of drug-resistant epilepsy. So that's what we're getting into now. And, people are certainly wary and scared about surgery for their epilepsy. And I frame it in the sense of, something that I certainly don't take lightly, but something that is definitely important because of that burden of epilepsy that I had mentioned. It's not just something that's, it's very easy to blow off epilepsy because it is a episodic disease, but it does have very real impact. And so we do want to be quite aggressive with trying to treat it. And so, this is an interesting study that came out a while ago now, but I keep bringing up because it really highlights the challenge that we as surgeons and clinicians overall have in terms of, quote unquote, trying to convince patients to have surgery for their epilepsy. This was a study done at SUNY Downstate, and they were looking into the patient beliefs about epilepsy and brain surgery. And if you look on the right-hand side, it really keys into very notable findings, is that frequently people thought that death or memory loss were, the majority of people thought that those were common things in brain surgery. And really it's not. And the real kicker here was that this one question that you see at the bottom here is, if your epilepsy doctor told you that brain surgery was guaranteed to stop your seizures without causing brain damage, would you be willing to have surgery? And, the shocking truth is that approximately half of patients, whether you had surgery or not, would say no. And the key words here are guaranteed to stop seizures. So effectively guaranteeing cure without risk. There's still the stigma that would prevent half of patients from pursuing that treatment. And so in truth, though, is quite different from that, is that epilepsy surgery is very safe. And that, ultimately, this quote from this article published recently is that the majority of complications after epilepsy surgery are minor or even temporary and tend to resolve completely, and that major permanent neurologic complications remain uncommon, and that ultimately, in this day and age, mortality or death is extremely rare. And you look at the numbers here from the study, is that minor complications that may be transient are in 5 to 8% of people. So the large majority of patients have none of these even. And then major complications are on the order of 0.5 or 1.5%, and certainly less than 1% chance of perioperative mortality. And that is certainly balanced with the efficacy. When we look at the efficacy of open surgery, when we talk about craniotomy or something that we've been doing now for decades, this has very good literature because it's been around for so long. When we look at something as common as a temporal lobectomy, where we remove the temporal lobe, if that is the source of seizures, we see that seizure freedom rates in the first couple of years are in the order of about 70%. And that over time, yes, it does diminish, but still more than half of patients remain seizure free, which is why, especially for temporal lobe epilepsy, we tend to be very much in support of surgical intervention because your chances are quite good. We do acknowledge that outside of the temporal lobe, those chances are lower, but and so certainly we'll weigh that into our decision for whether or not we recommend surgery. So, but regardless of this, it's still, quote unquote, brain surgery. And so, what I wanted to dive into more now is what are the more minimally invasive options that may be, more palatable in terms of pursuing for drug-resistant epilepsy, if you may not be willing to consider the traditional methods of craniotomy and removal of brain tissue. And so that's what, I was asked to focus on, is kind of the updates and what's new. So I wasn't going to go too much into the older forms of procedures. So when we talk about minimally invasive, we're going to focus here a little bit more on temporal lobe epilepsy, again, just because there's just more data associated with it. And, some of it that can translate to outside of the temporal lobe, but again, I'll focus a little bit more on temporal lobe epilepsy. At one point, gamma knife radiosurgery, so incisionless, where you're radiating part of the brain instead of open surgery, was pursued. There were two separate studies, one in France and one here in the US. The ROSE trial was the one performed here in the US. And ultimately what was found is that we did see order of 50 to 60% seizure freedom with gamma knife radiosurgery. So certainly less than that 70%. In this case, the open surgery group saw actually 80% chance seizure freedom, but you're looking at a difference between 70, 80% with the open surgery group versus 50 to 60 with the gamma knife group. And on top of that, what you can see here is that the effect of gamma knife takes time, and that's time that's in not so many words is wasted, because you have treatment early, but you don't get the effects of that treatment for at least 18 months. And so ultimately this study deemed that that radiosurgery was not terribly effective for temporal lobe epilepsy. So as an alternative minimally invasive option is where we come to laser ablation, which is something that is not super new now, but we've learned quite a lot about. In fact, we started doing it at Jefferson in 2012 when the technology came about. So it's been now about a decade of us doing laser ablation, and primarily for temporal lobe epilepsy. So I was going to talk a little bit more about the details of laser ablation. So I have a video here that shows kind of the steps that I'll talk through a little bit as well. Actually mute this. So with laser ablation, this is a minimally invasive procedure where we still have to make a small hole, but this hole is about 3 millimeters in diameter, so very small. And through that hole, we place this bone anchor, and that allows us to introduce this laser probe into the bone anchor and place it very precisely within 1 millimeter of our intended target. And that's usually where that is specifically where the seizures are coming from. And so this portion of the procedure is typically done in the operating room. We use all the technology possible to do this. So we're leveraging laser ablation. We actually put the laser in with the assistance of a surgical robot to improve accuracy. And then once the laser is in place, we take the patient down to the MRI scanner, because this procedure is actually done under MRI guidance. And that's the true benefit of it, is that we are able to see in real time exactly what we are ablating, what we are treating, and able to avoid areas that we might not want to treat. And so what we see in the operating room is something like this, where on the left we have a thermal map where we see the heat. And on the right-hand side, the software actually gives us an estimate of what the ultimate damage or ablation is going to be. So through this very small 3 millimeter hole, we're able to achieve a good ablation measuring approximately 4 centimeters in length of in this scenario, the mesial temporal lobe, which is often the cause of seizures in temporal lobe epilepsy. So, to better understand that, I was fortunate enough to lead a multi-center study where we looked at laser ablation across 13 different centers over 234 patients to have a better understanding of what were the outcomes and what were the factors associated with those outcomes. And ultimately what we saw is that about 56% of patients were seizure-free at 1 year, which is certainly lower than the open temporal lobectomy, but now you're comparing 70% seizure freedom with about 56%. But still you had almost 75% with significant seizure reduction, so meaningful improvement. We've now followed a lot of those patients out to an average of 4 years, and we still hit this number of about 50% being seizure-free, which is comparable to some of the numbers we're seeing with the open literature. And keep in mind, this is actually numbers from the early experience before we have learned some of the things that we know now. And so I believe that these numbers will actually improve and get closer to what we are seeing with open lobectomy with a minimally invasive procedure where, you know, it's an overnight stay as opposed to a much longer hospital course that needs, you know, intensive care with an open surgery. This, you don't need intensive care. It's an overnight stay and usually go home the next day. But this is one of the key points that we found in this study, is that the location absolutely matters in terms of where the ablation is, that we estimated effectively good outcome patients and suboptimal outcome patients. And so we highlight those in what you can see here in the location. The green circles versus the red circles are very different. And if we look at only the patients that had these optimally located ablations, it's associated with upwards of 70% chance of seizure freedom, so getting very close to open temporal lobectomy. So I think this is very important to understand, and the analogy that I have is that, you know, we can't look at laser ablation simply as a you know, monolithic single entity because it's not. It's like saying that, you know, one medication is going to act the same regardless of dose. Well, you have to use that, like Dr. Sinha was saying, you have to use that medication correctly. Same with laser ablation or any surgical approach, you have to use that surgical approach correctly. So if the laser ablation is not optimally located, that represents a suboptimal use of the therapy, not necessarily a failure of that therapy. So I think that's very important to understand. And so despite that, we're seeing numbers from this study get fairly close to open resection, still on the order of about 10% less. But I think with what we have learned, we're going to see that get much closer. And so part of that is this ongoing study that's being run by one of the companies that does make the laser, Medtronic. There's an ongoing study for laser ablation where we're looking into these outcomes and how the location of ablation plays a role. And it's called the SLATE study. It stands for stereotactic laser ablation for temporal lobe epilepsy. You always have to have a catchy name for a study. And so Jefferson is one of the sites where if you're a candidate, you can get enrolled in the study and help us better understand what exactly the nuances are of laser ablation for helping temporal lobe epilepsy. So, you know, no therapy is perfect. So the question always becomes, well, what if this doesn't work? Well, you know, just like open temporal lobectomy, there is a failure rate. And so there is a chance of failure after laser ablation, but it's, you know, to an extent, something that's easier to deal with if you've only had a minimally invasive procedure versus a open resection already. And what we found in this series of patients is that approximately 20 patients who failed ultimately went on to have a open resection. And we found that the seizure freedom rates were fairly comparable to if they just had an open resection to begin with. So you don't lose any ground. So ultimately, the stance and the perspective that this gives us is that, you know, you can try a minimally invasive option of laser ablation and it's much quicker recovery. And it still is surgery, but it's much, you know, more tolerable surgery. And if that happens to fail, you can always fall back on what we will still consider the gold standard of an open resection. So that option still exists. There are some patients laser ablation, and I think that also highlights the scenario where if the ablation was suboptimal in location, then there is a good reason to go back and re-ablate now that we understand that a little bit more. Moving a little bit away from temporal lobe epilepsy, I did want to bring up a couple other indications for laser ablation. One of them is typically seen more in children in the pediatric population, the hypothalamic hamartomas. It's an abnormal growth within the hypothalamus, which is deep in the brain. And I have a picture here of Dan Curry, who's a neurosurgeon at Texas Children's in Houston, and he has really led the field in laser ablation for hypothalamic hamartomas. And ultimately, he's shown that this is this should really become the new standard of care in terms of how we look at treatment of hypothalamic hamartomas. The cartoon on the right shows, how we used to approach this in open surgery, where you have to reach deep into the brain and all the structures along the way become at risk. And this is a very big surgery to recover from, as opposed to doing a laser ablation. Again, overnight stay, much lower complication rate. And we're still achieving very high rates of seizure freedom. In his series, greater than 90% seizure freedom in a good number of patients. So I think this is very rapidly becoming what should be considered first-line treatment for hypothalamic hamartomas as opposed to open surgery. The last part I want to talk about for laser ablation is cavernous malformations, which is a abnormal tangle of vessels that is typically associated with epilepsy. And the group in Emory has really led the way with this, and we've certainly done a number of laser ablations for cavernous malformations, and have found that this also works very well as opposed to doing an open procedure. If the location of the lesion is favorable, we can put a laser probe in it, burn it, again, go home the next day, and we're achieving rates of seizure freedom of greater than 80%. So very good outcomes with lesional epilepsy like this. So what I want to move on to is, I've talked about laser ablation and surgery in terms of treating the seizure onset zone, or where the seizures are coming from. And that's one of the main aspects of what we do in epilepsy surgery, is that we can only really treat and provide chance of seizure freedom for patients where we can very accurately identify where the seizure is coming from. And it becomes a very focal area of brain or abnormal tissue where the seizures are coming from. If that is true, then we can treat that brain as abnormal and say, if we either do a laser ablation or we take it out, it is something that gives a high chance of seizure freedom. So localizing seizure onset zone becomes very important. The challenge to that is, well, those areas of seizure onset can often be very close to important areas of the brain, like the motor cortex, the sensory cortex, things that control movement, sensation, speech, understanding, vision, as you see here. So mapping where that is relative to these eloquent areas of the brain becomes very important. And so the way that we do that now is very different than the way we did this a decade ago. A decade ago, this would typically require an open craniotomy, where we make, again, an incision, take off a window of bone and put electrodes on the surface of the brain. Now it looks something more like this, where we do a procedure called stereoelectroencephalography. And instead of just mapping the surface of the brain, we're actually mapping the three-dimensional anatomy of the brain and how that's related to where seizures start from, where they travel to, and where eloquent cortex is. So instead of making a big incision, we actually make these little tiny little holes. These are only 2 millimeters in size, and once these electrodes come out, this heals over very nicely. And this is much better tolerated than an open craniotomy. When we started doing this now 7-8 years ago, and when we first started, we're really struck by how well patients tolerated this over the standard methods. And so this minimally invasive way of mapping where seizures start and propagate and how they relate to other tissue is truly beneficial in terms of our way of understanding, and also ease of the procedure for patients. More importantly, my world is always about risk and benefit. SEEG is also much safer. And we did this analysis of looking at SEEG compared to traditional subdural electrodes, SDE here. And we see that rates of hemorrhage, infections, spinal fluid leak, abnormal lead placement, swelling, all these things are significantly lower. And again, you can see, coming back to that point, is that the rates of complications are very low in general, on the order of 1% or less. So, what if we do that and ultimately we decide that we cannot resect the seizure onset zone. Ultimately, we know that in patients with drug-resistant epilepsy, that surgical resection will be an option for about 2/3 of patients. But that leaves about a third of patients where we cannot help their epilepsy with an outright laser ablation or resection or something like that. Well, all is not lost because there are options of neurostimulation for epilepsy. And so you've likely heard about these: vagal nerve stimulation, deep brain stimulation, responsive neurostimulation. I'll go into each of these. But one key thing I want to mention is that these are typically thought of as second line in terms of surgical intervention, because when you talk about resection or laser ablation or removing tissue that's causing seizures, we're talking, as you saw in the data that I showed, that chances of seizure freedom, chances of ultimately effectively cure. When we look at neurostimulation, we're no longer talking about seizure freedom, we're talking about seizure reduction. Because in truth, the chances of seizure freedom with any of these technologies is quite low, and I'll show you those numbers. So I think it's very important to understand, neurostimulation is an option, but if we can offer a chance of cure, we would much rather do that. So going through each of these one at a time, vagal nerve stimulation is a procedure where we put a stimulator on the vagus nerve, which is in the neck, and it works because more than 80% of the fibers actually go back up to the brain, and it's been shown to affect the way that EEG is synchronized when you do vagal nerve stimulation. It's been approved since 1997, so a very established technology. And in general, what we see here is about 40 to 50% average seizure reduction. So again, not seizure freedom, but about seizures cut in half. That's in terms of both frequency and severity to a large degree. Now, there is a less than 10% chance of seizure freedom, so it is possible, but again, in the studies, quite low, less than 10%. It is a same-day procedure. It's done under general anesthesia and takes approximately 2 hours. It involves making an incision in the neck and implanting the electrode in the neck, and then also implanting the pulse generator or the battery over the chest wall under the collarbone. But one other thing that I wanted to bring up is that often people have the impression that because it's in the neck, it's a much safer, much less invasive procedure because it's not in the head. Again, this goes along with the whole stigma of brain surgery. I bring these anatomical drawings up because this is what we have to deal with in the operating room, is that when we do the surgery, we come in from the front, which is here where my arrow is, and the vagus nerve sits actually underneath and between the big artery called the common carotid and the big vein called the internal jugular vein. And so we actually have to move these aside. And so in the initial procedure, it's typically not high risk, but you have to understand that this artery is what feeds the entire left side of the brain, because we usually put this on the left side of the neck. And this vein is effectively what drains the entire left side of the brain. So if there's any injury to these, you're actually risking the entire side of the brain and not just a part of the brain. Now, again, that's not as big of a risk when it goes in, but the concern is if it has to get revised or fixed or removed, now you're dealing with an electrode that's on the vagus nerve with a lot of scar around here. So anytime I talk to patients about a revision or removal of a vagus nerve stimulator, I'm very careful to say that it's not as low risk as the implant, and that we have to consider this vascular anatomy. So very important to understand when we talk about vagus nerve stimulation, because when we talk about neurostimulation, we also want to consider, what are the downstream effects? Is it, how reversible is it, and so forth. So in terms of reversibility, yes, you can turn off the stimulator, but removing it entirely may be challenging. Moving on to deep brain stimulation, it was approved more recently in 2012 after conduction of the stimulation of the anterior nucleus for thalamus for epilepsy trial, otherwise known as the SANTE trial. And again, it's for treating drug-resistant epilepsy with focal onset seizures. And here we're seeing comparable rates of seizure reduction as with vagal nerve stimulation. In this study, it was about 40% mean seizure reduction and 6% seizure freedom. Again, so reasonable chance of seizure reduction, low chance of seizure freedom. Unlike vagal nerve stimulation, it does require a hospital stay, but one-night hospital stay. It's typically done under general anesthesia. It does take a little bit longer. It takes 4 hours as opposed to approximately 2 hours with a vagal nerve stimulator. So moving on to responsive neurostimulation. So the difference between deep brain stimulation and responsive neurostimulation is a couple things. Number one, with deep brain stimulation, we typically have a single target of the anterior nucleus of the thalamus. I'll go back, and that's deep within the brain here. Versus with responsive neurostimulation, the target may change and will be adjusted according to the specific needs of the patient, of where the actual seizure onset zone may be. Because of that, the stimulator and the fact that the stimulator only has 2 electrodes, that it's limited to no more than 2 epileptogenic foci or seizure onset zones. And so these may consist of a strip electrode that lays on the cortex, or a depth electrode that goes into brain. This is a video courtesy of NeuroPace, who makes the device. The generator, instead of on the chest, sits within the skull and is then connected to electrodes that go to that seizure onset zone. And so also, unlike deep brain stimulation, instead of stimulating all the time, it's actually recording from the brain at all times. And so it's not necessarily stimulating unless it detects a seizure. When it detects a seizure, then it'll stimulate to stop the seizure in its tracks, and then stop stimulating once the seizure has subsided. So that's why it's called responsive neurostimulation, is that it's recording at all times and stimulating only when necessary. It's effectively like a cardiac defibrillator, but for the brain and for epilepsy. So very similar concept there here. So with responsive neurostimulation, if you can see, we're going from generally a little less hospital stay to more. This is 1 to 2 night hospitalization, because there's a little bit more work that has to be done in the skull. Still under general anesthesia, still takes about 4 hours. When we look at seizure outcomes, the outcomes are a little bit better than with vagal nerve stimulation and deep brain stimulation. And a big part of this, again, is I think has to do with ability to localize where the seizures are coming from and stimulate right at those areas, as opposed to general broad stimulation. It's a little bit more precise as opposed to this shotgun approach. And so what we see is 40 to 50% mean seizure reduction and 15% chance seizure freedom. So both the rates of seizure reduction and chances of seizure freedom are a little bit higher. With all these neurostimulation technologies, it's also important to think about that there is a cumulative effect over time. And I encourage patients in general to be very patient with the results, because that the chances of seizure reduction and what we see with longer term outcomes is that seizure reduction actually increases over time, as you can see from this table here. So just to put it all together in one slide, I think going from least surgical involvement to most, from left to right, we also see the rates of seizure freedom are generally higher. These numbers are significantly higher than what you saw before, because again, there's generally increased efficacy over time. So when you look at 1 year versus 6 years, those numbers are quite different. So this cumulative effect over time certainly exists. But I think what is important to see here is that when we look at seizure-free periods, again, we're not talking about necessarily seizure freedom over years and years, but if you can have seizure freedom for at least 6 months at a time, that is possible in certainly all these cases, but again, not in the order of 70, 80%, more in the order of 10 to 20%. Now, as I wrap up, I have a few more slides. I just want to mention, living with a neurostimulation device is, unlike a resection where we're taking things out. In this case, we're putting things in. So you have to be aware of what are the potential consequences of that. The most relevant is certainly with electromagnetic interference. And so the most common scenario there, as you can see here, is going to be with security checks, TSA, airports, courthouses, sporting events, amusement parks, concerts. Anytime you have to stand in line to go through a security check or go through one of these detectors, I actually recommend that patients that have a stimulator don't do that and just get patted down, because although not a high chance, there is a chance that this electromagnetic interference could cause a disruption of therapy or actually cause outright malfunction of the device. Less common and specific to individual patients are, environmental or work-related electromagnetic interference sources, arc welding. If you work for Pico and you're near high transformers or high power lines, there's a laundry list of things. But for the majority of people, these things don't really come into play. It's really the security systems that most people have to be worried about. Before I talk about this, coming back to EMI, all these devices are actually MRI conditional, meaning that you can still get MRIs with the devices in. We just have to check that the device is in working order and get the right kind of MRI. We're in a day of age where no longer are we talking about inability to get MRIs once we put in a device. Instead, we flip to where you can get MRIs, it just has to be done in the right way. So, I've gone fairly quickly through a lot of different options because, epilepsy is diverse. It's complex, and there are certainly many surgical options. I think the important point to understand here is that surgery can cure epilepsy if you are the right candidate, and that it should be considered. And, what we know from the literature is that, unfortunately, epilepsy surgery remains significantly underutilized, primarily because there is this ongoing and very understandable fear. I live in a very different world where this is what I do day to day, so it seems commonplace to me, and I see the benefit that can provide the people. And so, that's why I believe in doing educational webinars like this to help spread that understanding and knowledge. So ultimately, again, epilepsy surgery is safe. There are many treatment options. And so, there's going to be, different shoes that fit different people. There are certainly newer and more minimally invasive options that are available, and it all depends on each patient's different situation. And so because of the diversity of things, I think the take-home message is that you shouldn't be afraid to ask your neurologist to talk with a neurosurgeon, or even just talk with your neurologist about it. I can guarantee you, if you go in to see a neurosurgeon, they're not going to walk in the room with a scalpel, right? They're going to talk to you about the surgery first, and ultimately is your decision. But I think it's certainly worthwhile to make a leap and get the information that you can get, as opposed to just being afraid to even get that information. I think that's where it can be most detrimental. So that's what I have for now. I wanted to leave enough time for questions. So I think we still have about 10 minutes or so. So I'll turn it back over to Seamus at this point.
All right, perfect. Thank you so much, Dr. Wu. That was a great presentation, a lot of great compliments. And one person did say they loved the pictures in your presentation, which I agree with them. Those were really good. So we do already have a few questions in the chat box that I'll happily read to you. But if anyone does have any other questions for Dr. Wu, please enter them in the chat box at this time. The first one, Dr. Wu, is someone who may be considering temporal surgery. They don't have a lesion on the brain, but would possibly be having that part of the brain removed where the seizures are starting from. Do you think this interstitial therapy would be a possible solution for someone? Oh, Dr. Wu, looks like we got you on mute. Sorry. There we go.
Classic. Yes, it's certainly possible, and this is, kind of getting to the point, is that it depends, right? So what we have learned over the years with laser interstitial thermal therapy is that, you don't necessarily have to have a lesion. What we do have to be confident about is the localization. And in fact, when we look at the, 200 plus patients from this multi-center study, is that whether or not there was a lesion or not, patients did just as well. And in fact, in that study, only 50% of patients had an outright lesion. So half of all patients were MRI negative. right? So there is certainly a possibility, depending on what all the other factors are in terms of, you have a PET scan that shows that, what does the EEG show? What do the seizures look like? And, all these other factors. And that's, all the different pieces of the puzzle that have to be put together to, put the whole picture together in terms of, is something like lit an appropriate option?
Perfect. Thank you very much. The next question we have is, what is Angle 1? Is that a seizure-free scale?
Yeah, so sorry. It's widely accepted, so sometimes I make the assumptions, but yes, the Engel classification is a seizure outcome scale where Engel 1 is free of seizures, and in fact, true seizure freedom is technically Engel 1A. If you're Engel 1 but not Engel 1A, it means you have auras but no seizures. So you're still not having outright seizures. So we consider that pretty good. Engel 2 is a significant, meaningful seizure reduction. So a lot of times, and I showed it in one slide, is that when we're looking at meaningful improvement, we look at Engel 1 and 2 together. But if we want to look at complete seizure freedom, that's Engel 1.
Perfect. Thank you very much. The next question we have is there a possible way to see where seizures are coming from, besides having to be in the epilepsy monitoring unit?
Great question. And the short answer is not yet. We rely heavily on the recordings of the brain because the way we think about it is that we want, if we're going to do surgery on the brain, we want to be darn sure that we're doing on the right part of the brain, right? And we want all those pieces to fit. So that's why, we get imaging, and that really primarily shows structure, right? Is there a structural abnormality? We may also get a PET scan, which does show some activity, but it's not very high resolution. It's very coarse. And so to really pinpoint that a little more, we want to see where is the abnormal activity really coming from. And the two benefits from being an EMU is the ability to see those recordings and be able to localize down to ideally a lobe or within a lobe where it might be coming from. But on top of that, that's always paired with video so that we have a very good sense of what we call the seizure semiology, or the way the seizures manifest, right? Because it's very hard to do that outside of the EMU. At the EMU, the video's on 24/7. So we will certainly catch the beginning of the seizure, which is the most important part, because the activity of the seizure will depend on the parts of the brain that are activated. And so I'll often have patients show me videos of their seizures at home. But, that has to be taken with a grain of salt, because by the time that someone's able to get their phone and start the recording, you've missed the beginning of the seizure, which is really the most critical portion of seeing how does the seizure start and how does it manifest, because that's going to be the biggest key of localizing where did the seizure start. And being able to see that in conjunction with the EEG gives us that extra confidence to say, okay, this is where seizures are coming from. So if we have video along with EEG, along with MRI, along with PET, and all these pieces of the puzzle fit together, that increases our level of confidence. So that's a long-winded way of saying ultimately, no, not yet.
No, that's a great answer. I appreciate that. Looks like we have a couple more questions. The next one is, can laser ablation surgery be used at the core of the brain?
So I'm guessing that means kind of at the center. The short answer is yes. I mean, the best example of that is the hypothalamic hamartomas that I showed. Those are pretty much right in the center. There are some people that have used laser in the thalamus, which is also a main hub, but that's very experimental at this time. So I guess the short answer is yes.
Perfect. Thank you. The next question is, somebody said, excellent presentation on searchable options and a complete eye opener. They want to know, would you encourage to consider surgery options early? And I think they're asking more depending on what age would you start to consider.
Yeah. So there's good evidence that generally says the earlier the better. There's a phenomenon that we know called kindling, and it is what it sounds like, is that, if we catch seizures early, we're catching it as we identify kind of the small area where it starts from. What can happen over time is that if that area is where the seizures come from, it will spread out through the rest of the brain. And if it does that over time, it will kindle the previously normal areas to become now abnormal. So under that whole concept is that the longer you wait, the more area of the brain has now become kindled and is harder to narrow down and localized. So in general, earlier surgery is better than later surgery. In terms of age-wise, I actually also go down to DuPont and do surgery on the children down there. I was there last week and did surgery on a 15-year-old, but I've operated all the way down to 6 months. So it is very, again, dependent on the case. And in fact, I'm always amazed by the procedures we do on children, because the brain at that age, especially you're talking about before adolescence, is so resilient that and the outcomes end up being overall better, just because kids just bounce back from everything very quickly. So it allows us to be a little bit more aggressive without causing any untoward harm. So that ultimately means better results overall. So again, it depends on each case, but yeah, we certainly operate on children very frequently.
Wonderful. Thank you for that great answer. Looks like another question that we have, I believe this person is asking, do seizures always follow like the same pattern? Meaning for someone with their epilepsy, do their seizures always start in the same area of the brain, or is it maybe possible for their seizures to start in multiple places?
Yeah, so we hope that it starts in the same area of the brain, and that's the exact scenario that we want for people that are candidates for surgery. That's exactly what we're trying to figure out, right? And so in patients where it does start from the same part of the brain every single time, then we can say, okay, if it's from the same part, then we can treat that part, right? And that is actually, fortunately, the more common scenario. There are a handful of scenarios is exactly that, where it just starts from the same part of the brain. There's a scenario where it's generalized epilepsy, where it starts from the entire brain, and those are cases that we generally can't offer surgery from. And there are scenarios where it starts from a couple different places. And so, the general concept that I think about is that if the seizures manifest or come about the same way every time, the exact same symptoms for each seizure, then it's likely coming from the same part of the brain. If the seizures each time you have them are different, then there's a greater chance that they may be actually coming from different parts of the brain, because again, if they're coming from the same part, it's going to activate that same cascade, that same pattern of symptoms. So more often than not, yes, they do follow the same pattern, and especially the patients that I see. But there are certain scenarios where if they don't, then unfortunately, those are not scenarios where we can offer curative surgery.
Oh, great. Thank you again, Dr. Wu. Looks like that is all the questions we have at this time. I really appreciate you taking the time to join us tonight, being one of our speakers. We really appreciate it, and appreciate all the questions, everyone, and for everyone attending. So I'm going to go ahead and share my screen real quick for everyone. So we just want to, again, say thank you to everyone for tuning in tonight. Great questions. Thank you to our sponsors again as well too. I did just launch a second poll. If everyone could please take the time to fill that out, we'd greatly appreciate it. But again, I just want to give big thank yous to Dr. Sinha and Dr. Wu for being our guest presenters tonight. We really appreciate it. The topics and material that you presented on and informed us all about. I know I learned a lot. It was very valuable to our community and everyone attending tonight. So thank you both again.
Thank you.
course. And everyone, please stay in contact with us. You have our main email you can reach out, our main website to stay updated on other conferences, webinars, and other programs and services going on as well too. And just to let everyone know, we are recording for tonight, so we will have a link a little bit later that will be available, so you can go back and rewatch the conference in case you missed any part of it as well. Perfect. Well, thank you again, everyone. Take care and have a great rest of your night.
Appreciate it. Thank you.